So my topic for today is optimizing challenges to drug therapy in heart failure with reduced ejection fraction. Good change from what we've been seeing since morning. A bit of pharmacology. So let me run through the slides and why this topic is very important for our daily practice. So in India, the mortality rate in heart failure with reduced ejection fraction patients increases with time, with a very dismal 3-year cumulative mortality rate being 46%. And in a hospital mortality rate being approximately 10%, and it increases as time passes. So one of the main reasons for this was basically lack of GDMT, which was associated with high risk of mortality in Indian patients with heart failure, especially with reduced ejection fraction. Optimal GDMT and all-cause mortality in heart failure patients. Data from the Trivandrum Heart Failure Registry in Kerala, India. So as it shows, suboptimal therapy or non-guideline directed therapy was associated with increased risk of mortality. Now, a very important point which I would like to mention here is some data from the Indian National Heart Failure Registry, which has accumulated around 11,000 patients so far across 53 centers in 21 states. And very surprisingly, this study was done between 2019 to 20, just pre-COVID era. And the results are very surprising, wherein only 47.5% patients are receiving GDMT, out of which a very abysmal 5 to 10% are receiving ARNI. So, well, with such a broad data and only 10% receiving ARNI is really surprising, even with a 4-year back data. And the mortality rate in this group was around 15% at 90 days and a very staggering almost 46% at 3 years post extrapolation. So an essential way to combat heart failure, although heart failure is a major cause of mortality worldwide, effective medical therapy exists with data to reduce morbidity and mortality. Joint guidelines recommend that patients with heart failure with reduced ejection fraction are treated with maximally tolerated doses of appropriate neurohormonal blockers to improve patient outcomes. Current guidelines recommend guideline-directed medical therapy. Say, for example, a 58-year-old female with NYHA class 2, currently on ACI, beta blocker, diuretic, and an MRA. She is able to do her routine work. Occasionally, she takes a break, and then again, she resumes her work. So, what do you do now? So with current therapy, she's in NYHA class 2. So now, according to our latest guidelines, definitely this ACI should be changed to ARNI. Now her echo shows EF of 35% and NT-proBNP levels of 125. She's not congested. Her BMI is 27.5. Her creatinine, potassium and blood pressure are all okay. So what will be your next step? So definitely this patient needs to be switched over to ARNI according to our latest guidelines. It's a class 1A recommendation. And here as the patient is receiving already beta blocker, diuretic and an MRA, definitely an SGLT2 addition would be ideal. Lack of GDMT was independently associated with increased mortality, as I've already said. Patients not on GDMT cohort had a 29% increased risk of mortality compared to patients on GDMT. So all the trials have repeatedly said this. So guideline recommendations on GDMT in heart failure with reduced ejection fraction patients. Hospitalization for HFrEF is a critical opportunity to continue, initiate and further optimize GDMT. So well, in this National Heart Failure Registry, 75% of patients were de novo heart failure patients. So this should be used as an opportunity to initiate this particular treatment and further optimize prior to discharge. Continuation of oral GDMT during hospitalization for heart failure has been shown in registries to lower risk of post-discharge death and readmission compared with discontinuation. So in chronic symptomatic HFrEF, NYHA class 2 or 3, who tolerate an ACI or ARB, replacement by an ARNI is recommended. ARNI is recommended as the first-line therapy for HFrEF patients, and it is recommended as de novo treatment in hospitalized patients with acute heart failure before discharge after stabilization. ARNI may be considered as a first-line therapy instead of an ACI in all HFrEF patients. Initiation of this particular drug in recently hospitalized stable patients with HFrEF, including those who are ACI-ARB naive, is safe and may be considered. That is de novo heart failure patients who have had no run-in with ACAR. So evidence backing the use of ARNI is ample. It keeps HFrEF patients out of hospital and makes them live longer, with definite improvements in primary composite of cardiovascular death and recurrent heart failure hospitalizations. 61% of HFrEF patients post-discharge achieve target dose of sacubitril valsartan by week 26, which is very important. Optimal dose is definitely important in reduction of mortality. So ARNI up titration achieved target dose with simultaneous initiation and or up titration of beta blockers and MRAs by week 26. So despite all this evidence and all our knowledge, and we all know what to do, the use of ARNI is very, very low in India. As I was just mentioning, the National Heart Failure Registry, the use of ARNI is really, really dismal, wherein HFrEF patients, only 4.8% of all patients, so less than 4% in Indian heart failure patients. This data is very, very surprising and shocking, especially with today the cost being very effective and the drug being very accessible to the patients. Of course, this data is 4 years old and maybe things may have improved, but definitely needs prompt attention. So major barriers to medication titration. Though treatment with HFrEF is well determined by guidelines, innumerable situations may limit the implementation of GDMT, be it physician inertia or patient non-compliance, economic, socio-economic issues, and adverse effects. So some patients may not tolerate medications or recommended doses or may have side effects. In some cases, there is an excess of caution, failing to prescribe the recommended treatment, fearing complications. In most cases, the reasons for non-prescription of underdosing or underdosing of GDMT by treating clinicians were non-apparent. Amongst the reasons given, hypotension was the most commonest cause, especially with non-cardiology based therapies, that is non-cardiology centers. So overcoming barriers to optimize GDMT, apart from physician inertia and patient non-compliance, what we can do clinically, the factors most commonly are hypertension, hyperkalemia and renal impairment. So let's talk about hypotension with HFrEF therapy, the challenge. So patients with HFrEF plus hypertension often undertreated with disease modifying therapy because hypertension of course is associated with poor outcomes. So how do we break this vicious cycle? Inertia regarding hypertension or adverse effects regarding hypertension. Patients with heart failure have activated neurohormonal systems. So basically RAS inhibitors, beta blockers, MRAs, vasodilators antagonize these effects and reduce afterload, relieving cardiac work, can lead to lower BP. So data in the literature suggests that lower BP is actually a marker that your ARNI therapy or your GDMT therapy is actually being effective. Not that hypertension is good for the patient, but probably in a patient with HFrEF, you're not going to expect that the patient is having a BP of 120. The BP may be ranging around 90 to 100, but it is more important that you consider symptomatic hypertension rather than just hypertension. So therapy should not be withdrawn unless the patient is symptomatic and the systolic blood pressure goes less than 90. The main limiting factor in the treatment of heart failure is not hypertension, but the lack of understanding of the concept of hypertension, as I just mentioned. So diagnosis of hypertension cannot be relied only on an absolute value of BP. Adequately medicated heart failure patients usually have systolic BP as low as 90 with no symptoms. So this should be definitely kept in mind. A patient of this type, when presented with normal BP 120 by 80, may be sub-medicated, considering that the pressure is normal. So therefore, for any change in therapy, symptoms of hypertension need to be present for you to down titrate or stop the medication. So in case of symptomatic hypertension, which drug to discontinue first? So in case of no objective signs of congestion, discontinue the diuretic dose first, as this would be the drug which would be least effective in mortality. So I would first reduce my diuretic dose, then reduce dose of stop nitrate hydrazine combination if any. Hypotension may be most often due to diuretics rather than your ARNI therapy. RAS blockers are the last in the list to reduce while managing hypertension. Last on the list, why? Because their benefits are greatest. So impact of ARNI on low systolic blood pressure. So 12% reduction in risk of CV death or heart failure hospitalization in HFrEF patients with low systolic blood pressure. Mind you, this is not related to hypertension, but more with regards to efficacy of your drug therapy. And significantly lower risk of death with ARNI despite a hypertensive event. I'm not saying that hypertension is good here for the patient. It is just a marker that our therapy is being effective if the patient is not symptomatic with this hypertension. Hyperkalemia, again a very regular concern while treating with ARNI. So disorders of potassium homeostasis can potentiate the already elevated risk of arrhythmia and heart failure. These patients have a high prevalence of CKD, which further heightens the risk of hyperkalemia. With growing numbers of CKD in heart failure patients taking RAS inhibitors, ARNI and MRAs, hyperkalemia has become a more common concern. But of course, as I have also seen and written in literature, it was more of a problem with ACRB rather than ARNI. Definitely combined with MRAs, there is an issue of hyperkalemia which needs to be carefully monitored, but that does not lead to discontinuation of therapy. Of course, hyperkalemia increases with decline in renal function. Impaired renal function increases the risk of hyperkalemia in both the patients taking placebo and the MRA treated patients. 9% of patients admitted for acute heart failure present with hyperkalemia. 10 to 38% of hospitalized patients who received an ACI developed hyperkalemia. 10% of patients prescribed an ACI developed severe hyperkalemia within 1 year of follow-up. However, reduction of RAS inhibition may lead to poorer outcomes, that is CV death and heart failure hospitalizations. So, impact of ARNI on serum potassium levels. Serum potassium level was persistently lower with ARNI as compared to enalapril, which we have also seen in multiple studies. So, it should not be a real problem, as also I have seen in my routine clinical practice. Very often, your hyperkalemia may be really because of the MRA and not because of the ARNI. So, suggestive would be to either down titrate the MRA or stop the MRA temporarily, but not reduce the dose of ARNI. Similar rates of hyperkalemia in MRA treated patients. Risk of severe hyperkalemia is significantly higher with enalapril as compared to ARNI. Renal impairment. Another unwanted barrier in heart failure therapy. Over the last 30 years, RAS inhibition have shown incremental benefits and improved quality of life, reduced hospitalization and mortality rates. However, worsening renal function is common during heart failure therapy and has been associated with decreased survival, hospitalization and disease progression. Renal dysfunction is one of the strongest predictors of adverse outcomes in acute decompensated heart failure. The cause of worsening renal function during a decompensated episode needs careful thought, particularly regarding the volume status of patient and whether the RAS inhibitors are of prognostic benefit. Impact of ARNI on renal function. Well, the combined effect of angiotensin 2 inhibition and neprilysin inhibition. So what it does is it basically causes a selective vasorelaxation of the preglomerular afferent arterioles and a selective vasoconstriction of the postglomerular afferent arterioles, leading to an increase in the intracapillary hydrostatic pressure, and hence it increases the eGFR, which is our target here. So the eGFR actually improves with ARNI therapy because of its pharmacological effects, and definitely as we are currently using our ARNI with an eGFR of above 30, lower than that with CKD stage 4 and 5, the data is not robust enough as of now. Probably it may come into routine use there also. Significantly lower reports of serum creatinine greater than 2.5 with ARNI as compared to enalapril. So impact of ARNI on renal function. Lower rate of discontinuation of treatment with ARNI. Significant improvement in eGFR with ARNI, as I just stated the pharmacological mechanism, in real world setting with HFrEF patients with CKD. There is 11% reduction in risk of worsening renal function with ARNI as compared to ACRB in HFrEF patients. So initiation and optimization of ARNI based on eGFR levels as recommended by ACC. So mild greater than 60, no dose adjustment is required. Moderate, that is eGFR of 59 to 30, CKD stage 3, no dose adjustment required, we are using routinely. Severe 50, but again with caution, with very end-stage renal disease, there is no robust data regarding its use, but it may be used depending on the subjective clinical condition of the patient and being monitored for progressive renal or worsening renal function and stopping the drug as required. So in conclusion, lack of GDMT was associated with a higher risk of mortality in Indian heart failure patients. ARNI is recommended as first-line therapy for all HFrEF patients, but use of ARNI is very, very low in India, as just our data said, around 5%. ARNI has good overall safety profile, significantly lower risk of death with ARNI despite a hypotensive event. Serum potassium level was persistently lower with ARNI as compared to enalapril, and significantly lower reports of worsening renal function with ARNI as compared to enalapril. Thank you.